Hi, my name's Bea. I'm one of the third year medical students. I am currently doing laparoscopic surgery at the Delta Centre, and me and two other students have created a teaching series on how to become a surgeon. And today I will be covering abdominal emergencies. So let's get started. So we'll start off with appendicitis. So, what is it? So, any word ending in itis means inflammation. So, appendicitis is inflammation of the appendix, usually due to fecalith, but it can also be due to a tumour or impacted feces. So we've got a nice picture there showing the, let me put my pointer on. So the appendix that is normally found here that looks quite inflamed. So what symptoms do patients present with? So they tend to present with poorly localized pain first in the periumbilical area, so around here. This then becomes localized to the right lower quadrant here, which is called the McBurney's point, especially where the appendix is. They might also present with loss of appetite depending on how acute their appendicitis is, and nausea and vomiting, and also potentially a low-grade fever because this is inflammation, infection, so they might present with a fever. The key thing to remember is if they present with a high-grade fever, tachycardia, so a fast heart rate, and generalized abdominal pain, they can't localize it, then think perforation of the appendix, because these signs are signs of peritonitis, which is inflammation of the peritoneal cavity. So that will just show that the appendix has burst, the contents have spread into the peritoneal cavity and caused peritonitis. So that is a really key thing for you to remember. Okay, then in terms of what investigations you'd want to do. So we'll start off with a urinalysis, really easy investigation to do to rule out any renal or urological cause because it is, in the right lower quadrant. We also want to do a pregnancy test in women of reproductive age to rule out any ectopic pregnancies. Then we want to do full blood count, CRP looking for any inflammation, group and save to look for the patient's blood type, and also clotting, because if we need to do surgery, we need to make sure that that their clotting is within range. In terms of imaging, an ultrasound is a very good first line if you're suspecting pregnancy because it means that there is no radiation to the pregnant lady. But the gold standard is a CT abdomen pelvis with IV contrast. So that is a picture of a CT abdomen pelvis, and you look at it thinking you are looking at the patient from the feet up. So this is the right side, this is the left side, the patient's right side, the patient's left side. So here you can see the appendix, it is nicely labelled for us and it is enlarged. So this is showing appendicitis. Okay. So in terms of treatment, this will really depend on the severity of the appendicitis. If it's uncomplicated, we go for a laparoscopic appendectomy or appendicectomy, however you want to call it, with IV antibiotics. So here is a picture of what that looks like. So there are 3 ports. So one with the camera through the umbilicus, that tends to be where the camera goes through, and then 2 others for the surgical tools to go through. So it's very nice for scars because you only get 3 little scars instead of with an open procedure, you get a much bigger scar. However, if the appendix is perforated, then we need to do emergency surgery because this will turn into peritonitis. We want to do a peritoneal washout to wash out the appendix contents from the peritoneal cavity. And again, we want to give IV antibiotics. So that's appendicitis, common symptoms, and kind of the investigations and the treatment that you'd go ahead with for appendicitis. Then we have bowel obstruction. So what is it? So bowel obstruction is a mechanical blockage of the bowel that will result, as you can see in the picture, a blockage here. It will build up proximal to that blockage, and it will cause some back pressure, which this means that this can go back up the GI tract and cause vomiting and dilatation of the intestines. So there's both small bowel and large bowel obstruction. However, small bowel is a lot more common than large bowel obstruction. In terms of causes, the causes for small bowel obstruction and for large bowel obstruction are different. So for small bowel, the most common one tends to be adhesions. So you can get adhesions from abdominal surgeries. Previous abdominal surgeries will increase your likelihood of a small bowel obstruction due to adhesions. And also less likely, but still a cause, is hernias. Then we have large bowel obstruction, of which the most common cause is malignancy, but you can also have diverticular disease and volvulus causing a large bowel obstruction. Then, in terms of what symptoms and signs you want to look out for, so the patient might present with vomiting, especially if they describe it as green. It's called green bilious vomiting. That tends to be early in proximal and late in distal obstruction. So if you think about the intestines, it makes sense that it will be early in proximal because it's further up close to the stomach and the biliary tree. Then you also might get abdominal pain, especially secondary to the bowel peristalsis. So when the bowel is contracting, that is obviously causing pain because it's trying to contract through that obstruction. You might also get absolute constipation. Again, it's early in distal because the distal is lower to the anus and the rectum, and late in proximal obstruction. But a key symptom is lack of flatulence, so lack of passing wind. On examination, on auscultation, it's said to hear tinkling bowel sounds, and also on percussion, it may give you a tympanic sound. So, and what investigations you'd want to carry out for bowel obstruction? So you want to do urgent bloods, like we mentioned before, so FBCs, CRPs. You want to do group and save, and you really want to monitor the user-knees, because there's a thing that can occur called third spacing in bowel obstruction, which is when the back pressure behind the obstruction will cause the fluids to shift between the intestine and the outside. So you can have fluid shifting. So that will really change the electrolyte concentration. So you really want to look at the user-knees. Then you also want to do a VBG. Look out for the lactate, and also look for any metabolic alkalosis that can be present with bowel obstruction. Then if we move on to imaging, you can do, so the gold standard is a CT scan with IV contrast of the abdomen pelvis. That will really show you the presence of bowel obstruction or not presence, and also the cause, because you can see the whole of the abdomen. You could also do an abdominal x-ray. It will show dilated bowel. In the small bowel, that means that it is over 3 centimeters. So as we can see here, we can see that it's small bowel because we can see the valvulae conniventes, which are running through the whole length of the bowel, and it's quite central. But we can see that it is over 3 centimeters, so it is dilated. In terms of the large bowel, you can see, so depending on whereabouts it is, it can be over 6 centimeters or 9 centimeters. So we can see here, we can't see valvular lines running through. So this is the large bowel, and we can see that it is dilated because it is over 6 centimeters. Here is a CT scan of the abdomen pelvis, showing a bowel obstruction. As you can see here, the bowel loops, you can see that they are obstructed. So that is a CT scan. CT scan is a bit harder to read than the x-rays, but you can see the really dilated bowel loops here on the CT scan. Okay. So we start off with conservative management. So it's a thing called drip and suck. So what that involves is you give a drip, so you give IV fluids, and make sure to correct any electrolyte imbalances. So as we were mentioning before, the third spacing, you can get electrolyte imbalances. So you really want to make sure that these are, controlled. Then the suck part of it is you make your patient kneel by mouth, and you insert an NG tube like shown here in the picture to decompress the bowel. You can see it goes down here, and it will mean that it will decompress whatever is, proximal to the obstruction. They may need a urinary catheter, and you really want to look at their fluid balance. You can also give them analgesia as required and antiemetics if they are vomiting. If this is not enough, then you do a water-soluble contrast study. So this is an abdominal x-ray after 6 hours of the contrast given orally. It tends to be used for ongoing obstruction, but it tends to have really good resolutions. Then if that is not enough, then we move on to surgical management. So we can do a laparotomy. So we do that especially when we suspect that the cause of the bowel obstruction is something that requires surgical correction. So something like a strangulated hernia will definitely need surgical management. So we go straight into a laparotomy. You also do it if you suspect intestinal ischemia and also a closed loop obstruction. So a closed loop obstruction is there is the blockage here, and then there is the ileocecal valve, and between those 2 points, the bowel is obstructed, and the pressure increases, and it really just needs to be decompressed, because if it's between 2 points, then there is no movement of that area of bowel. We also do surgical management if the patient fails to improve after the conservative measures after 48 hours. So the patient may need a resection of the bowel. If they do, then a defunctioning stoma bag may be necessary to be placed. You can see here in the picture the difference between the two things. So laparoscopy, you go in through the 3 surgical ports, and then laparotomy is an open procedure. So it's a really nice diagram to show you the difference between the two. So those are the 2 main common, abdominal emergencies that you need to be aware of. Hopefully that made sense, and you are aware of the symptoms that the patients can present with, and the different surgical managements and also conservative managements that you can apply to these patients.